Me llamo Tomás Campitelli. Estoy un trabajador de Barbell Medicina. Medicina de Barbell? Yo no sé. I'm really actually the kind of heart of the operation.
I heard that Tom Campitelli went to the games in 2008. Is that true?
It is. I've seen the video of him preparing for the games. I've seen him in the rankings.
God, man. Ever since he made the games in 2008, he just doesn't stop talking about it. And he's running around doing 400-meter laps around the neighborhood, doing burpees at every corner. He just, always feels like he has to be sweating every time.
He's a real nice guy, but I'll tell you what, he's a bit extra. He is always working out. But just push-ups, burpees, bodyweight squats.
Very impressive. Very.
Tom, we heard that you went to the CrossFit Games in 2008.
True. I was 2 or 3 from the bottom.
Hey, you've never stopped exercising.
No. I'm driven to be the best.
I think he's playing the long game, so he's trying to preserve that skin for as long as possible. So when he's 80 and ready to show off his body, like his skin is still going to be fantastic.
I mean, I will grant you that I've aged pretty well. I don't tell people how old I am. I will say I'm definitely over 68 years old.
Question is flexibility tests. What do we think of them? Why are they so common? So I think if you're looking for data that suggests that any particular performance on any flexibility measure is predictive of either performance, a reduction in injury prevalence or incidence, reduction in report of pain incidence, or mortality, or you're not going to find it because it doesn't exist. So any flexibility performance metric that is out there doesn't correlate to anything, but it's easy to test. I have this box from 1972. You put your feet against it, and then you push this little slider. There's a number that's still on here because it was made with bomb-proof paint. Okay, and that's it. So I think that if you are subjected to a flexibility test, that your next best move is to remove yourself from whatever situation, put you into that original situation, because that's a bad thing to be in. If those people are providing you with an education, right? I mean, that's a bigger problem, don't you think? Yeah. So I think if you ask your professors, like, hey, why are you doing this? And they feed you any line other than we're forced to, then you have to leave.
I think he's getting a little disinhibited here.
No, I'm not. All right, Austin, let me ask you this. Does flexibility predict anything about anything?
Other than flexibility?
Other than that specific test at that specific time?
It's not useful.
Okay, so if somebody in a position of power made you do this thing for anything other than a research paper that granted them tenure at their university, would you say that that is a good use of people's time?
No.
Then why are you disagreeing with me?
So if somebody's wrong about one thing, is that enough to put the whole thing out?
I think that if you are in an institution of higher learning and you're paying for a particular set of skills and a credential, and they're showing you that they are not equipped to provide you with that higher set of skills and credential potentially, then you should not continue to pay for that service. Okay? It doesn't mean that they're bad humans. It's just that I couldn't ethically test your flexibility and tell you anything about anything. other than, hey man, on this particular day in history, your sit and reach test was this, and it means nothing, which is exactly what it means. So why is it so prevalent? Again, I don't know, other than people in the 1970s decided to purchase all these sit and reach box tests because the presidential fitness test was a thing, and now they're prevalent, and people, what are they gonna do, test your squat? Here's the other thing. All right, so check this out. Let me make this one step further. If they test your flexibility and then you ask them, well, why don't we just test our squat? And they say, well, squats are bad for your knees. You have to leave. Is that sensitive enough for you? All I'm getting at is that if you have people like that who are teaching you, then they're not equipped to provide you with any further knowledge that you need.
Funny story to add to that. So the professor, he does CrossFit.
Oh, sick.
And I told him I'm more into like powerlifting. And he asked me if I do high bar, low bar.
Oh,
low bar.
Yeah.
And he's like, ooh, how do your hips feel? So I feel good. And then he's like, oh, did you know that shoulder positioning puts torque on your shoulders, like the bar positioning puts torque on your shoulders? Oh, really? Okay.
Did you ask him what his best squat was?
No.
I would have tried to level up. What's your best squat, bro? Yeah, and he's gonna say 225, and you say, yeah, I did that for a set of 30 for fun because Feigenbaum said I could get some hypertrophy for that, and I was tired, so I just did that. Yeah, I did your best for a set of 30, so torque this, brah. Also, again, I just want to let you know, my aptly scratched this. The internet's gonna love this. All right. So the question is about the validity of the waist circumference measurement as it pertains to as it pertains to body fat level versus visceral organ size. So yes, there's a robust data sets where they measure waist circumference versus body fat, like actually being analyzed and seeing which one is more predictive, and waist circumference and BMI are sensitive and specific enough to the diseases associated with obesity. They're more sensitive and more specific than body fat analysis, suggesting that they accurately predict whether someone is carrying too much body fat tissue, where you wouldn't need to do a body fat analysis test. So the question would be, do people with larger frame sizes generally have larger visceral organ tissue? That's not necessarily the case. Yeah. And further, do people who have higher BMIs and higher waist circumferences typically have higher amounts of visceral adipose tissue? And the answer is yes, they do. So yeah, it's been studied, and the answer is if you have elevated BMI with an elevated waist circumference that's above that cutoff level. What just happened?
I had to zip my fly up.
Oh, nice. So if you have an elevated BMI and elevated waist circumference, then we can be reasonably sure that that's due to too much adipose tissue in your abdomen. Yeah, which is why like the American Board of Obesity Medicine recommends against testing for body fat, because they're like, it doesn't add anything to your clinical picture, just extra resources that are being expended. So the question would be, should you rotate your hand at the top of a row to prevent injury? The answer to that is no. And the further answer is, it'd be very difficult to describe a particular biomechanical situation that predisposes someone to overt injury under a barbell or under a dumbbell even. And further, it's even more difficult to describe what even an injury actually is. So, in fact, the current definition that's being used is from a 2014 study by Timka in Sports Medicine Journal. It would suggest that any thing that produces a morphology change, so like a deformity,
limb, like an open fracture.
Like you have an open fracture or like an obvious muscle rupture, or that reduces function significantly, is an injury. Although you could say that a severe case of delayed onset muscle soreness would technically therefore be an injury, but in any event, that's how they define it. So does rotating the dumbbell at the top prevent that from happening? Not to anything that's ever been shown in the literature. And then further, so let's think about a squat. If your knees cave in when you squat, right? Or if your back rounds, or if your elbows shoot up, or if your head cranes up. These are all compromises in the technical efficiency of the movement, all right, which may ultimately compromise performance on the lift, but do they predispose you to developing injury? Not that's been shown reliably. And based on Austin's pain lecture, you know that pain is super complex, so we wouldn't necessarily expect folks to be in more or less pain based on how they exercised, unless their acute on chronic workload management was inappropriate, meaning they did too much too soon, for instance.
Yeah.
So
I think the injury risk piece comes way overwhelmingly more down to load management than it does to the way you are moving.
Yeah.
Movement in general is safe, and I think trying to dichotomize things into correct or incorrect movement is wrong.
I think it's a sales tactic.
Yeah. So this is my method of movement that is correct, and all these other methods of movement are incorrect.
Pay me.
Because if you move those other ways, you will snap your shit up. Right? I think that's wrong, and I think it's harmful. We're resilient, robust, adaptable organisms. We can move in a variety of ways. We can adapt a variety of postures. And I think that suggesting that failure to rotate your arm during a dumbbell row will cause injury is ridiculous.
You'll impinge your shoulder.
Yes.
Which is not even a thing.
Which is a whole separate topic.
Not a thing.
Well, kind of, but not really. So
it's like a VMO. Like there are fibers that are oblique, but it's not like its own separate entity. Sure. Yeah, sure. All right. No. Okay. So the question is, are there any studies, screening tests, medical nuggets of info that you would give to anyone to improve their health and performance?
Well, to catch diagnosis of sleep apnea. Sounds like, right?
Anything.
Are there other things that
yes. So widely based, population-based screening tests that have been shown to be efficacious for improving health outcomes.
It's a big topic.
Yeah, well, I think that the USPTF, so U.S. Preventative Services Task Force.
There you go. Nailed it.
Comes up with these recommendations that are age-appropriate screenings based on your demographic and risk factors. And I think that's the best population-based evidence stuff that we have to date. So depending on your background, your medical history, etc., you would be subjected to certain tests on a regular basis that your doctor would do to fulfill their criteria in order to be paid. So if you were to go see them, they would have to do so. So there's that. I don't have any problem recommending that everybody should take the Stop Bang questionnaire. I don't have any problem doing that. I have problems saying that everybody should get a CBC and a CMP and other certain vitamin levels, because that's on a case-by-case basis. And I think that if you are just drawing labs to try to find a problem, you may in fact find a problem that doesn't necessarily need to be treated. So the USPSTF, there you go, has the current guidelines that I would follow at this time. Do you have a different answer?
No, I mean, I think that's where I would go on this stuff too. I think we're probably going to include the Stop Bang in the booklets for people next time, probably, so they can take it while they're here.
Yeah, we're going to start selling a Barbell Medicine sleep apnea machine.
Yeah, and I think that, if you go to the USPSTF website, you'll probably not find something that is going to radically change your life on the same level that getting diagnosed and treated for sleep apnea will, unless you have untreated or undiagnosed depression, which is recommended to be screened for, untreated or undiagnosed alcohol or drug use, which is recommended to be screened for, undiagnosed or untreated HIV infection, which is recommended to be screened for. Those are probably the big ones.
Yeah.
At what I'm guessing is your age, just looking at you.
He's actually 75.
Oh, wow.
Yeah, which you don't know.
That changes my answer a little bit.
Yeah, right. Don't they recommend for testosterone screenings?
That's going to be a no.
No,
for anyone.
I see.
At any age.
And vitamin D?
Nope.
Oh, weird.
So the question is from a physician in our audience who...
She's a doctor.
Yes. So the question has to do with the application of the biopsychosocial model to health and disease, particularly pertaining to weight loss, success, or failure.
In other words, people who have failed multiple times and having psychological trauma or stigma and things like that associated with their prior weight management issues and interaction with healthcare providers. How do we approach that?
Yeah, I mean, I can only tell you how I approach it. And for me, it's not necessarily... So I would go back to your statement that the calories in, calories out doesn't work. I agree that it doesn't work from a population level recommendation standpoint. No more than the CrossFit recommendation of get off the carbs, off the couch is going to work at a population level. I think that all it's showing us is that we need a more specific recommendation, and we need to have a set of guidelines that's an algorithm effectively that's pushing us through how we go about managing obesity, right? And I think that exists. The endocrinology,
The ACE obesity guidelines are quite good.
Yeah, the American Association of Clinical Endocrinologists, their obesity guidelines are top notch. ABOM, American Board of Obesity Medicine, their obesity management recommendations are also top notch. What you find is that they always start with lifestyle, right? It's just like this little thing, lifestyle medicine. It's like, cool. So how are you counseling people? And what are you recommending? So I think that the recommendations need to be specific. And I think that the only way that you can make specific recommendations that aren't harmful to the patient population is by getting a good history, right? So you have to ask their diet history. Well, what have you done in the past? What has worked? What has not worked? And why did you think it stopped working? Whatever was working before. And I think that being sensitive, I mean, that's the same thing you do with any other disease, right? And then you just move on down the algorithm. So if this person happens to have a BMI greater than 35, then you have to approach right there at that point. Hey, I think at some point we need to have you see one of our surgeons because you would be a good candidate potentially for surgery. You may require medications, and you want to destigmatize that right off the bat. I think the bigger problem isn't necessarily offending or making the patient upset, because I don't think that hasn't been my experience anyway. The bigger problem is not treating them to the level which they need to be treated. I mean, how many patients do you know between you and your colleagues who are on obesity, anti-obesity medications?
I do a lot of obesity.
You do. So you do a lot. What about your colleagues?
Based on your patient's needs.
Yeah, right, exactly. So you're the person. Yeah, so that's a problem. Not necessarily that you're busy, but that they're so outside of, their primary care as well, I assume, right? We'd want them to be able to do this, or at least have more resources like you who are doing this. That's a problem. Further, being able to refer to surgery, that needs to be destigmatized. So I think starting the conversations early needs to happen, and I think that getting a good history on the patient as far as what has worked for them in the past and why it stopped working is important, because you need to point out, like, hey, you think that keto is the only way that you lose weight, except for you've tried it 6 times and it still hasn't worked. It still hasn't worked for you. And it's not that you're trying to offend them, you're just trying to point out the obvious. And I think that's the same thing you do for people who end up having diabetes and high blood pressure as well. You're like, what we've been doing in the past hasn't worked. So
yeah, I think I take a similar approach to this that I probably take with a lot of the pain stuff that I deal with, in terms of first kind of figuring out where the patient is, what's their understanding of what's going on, how they ended up here, what's going on, and then kind of the stages of change kind of thing, figuring out how likely are they to dive into this. And if they've tried multiple times before, that's a good sign. It means they're willing to try, right? But then why did it stop, or what are the current ongoing barriers? Right? What have you been told before about your obesity? What have other physicians told you about this? And that's oftentimes where you might see people start to open up and get some tears flowing if they've been told bad things, or if they felt, shame or, negative connotations with, because the majority of these people avoid doctors. They don't like going to the doctor because they know that when they go to the doctor, they have to step on the scale when they go in the office. That's not cool. Right? Because when you avoid getting healthcare, getting help for your problems, what happens? It comes back to bite you later on, right? With stuff that's been untreated or undiagnosed, or because you didn't go to your doctor, because you're afraid to step on the scale, you missed your age-appropriate cancer screenings, and then you get diagnosed with things like cancer, breast cancer, colon cancer at a higher rate because you didn't get things like mammograms and colonoscopies done and stuff like that. That's also been shown among patients who tend to avoid going to healthcare providers for these sorts of reasons. So totally agree that I think destigmatizing is probably the way to go, and the way to do that is to establish rapport, and the way to establish rapport is just talking to people more. And that's, I mean, when I have a patient, particularly, I do plenty of obesity stuff and do the obesity medicine piece, but a lot of pain stuff as well, and it's just lots of talking. And once you can establish that rapport, you can identify barriers. Once you identify barriers, you can start to take those down. Because if you identify a barrier, like for example, the patient says, I under no circumstances can adhere to a fat restricted diet, for example, right? Then you've identified a potential avenue where you can steer them down, and maybe we need to manipulate their energy intake from a carbohydrate standpoint instead. So identifying barriers is a big piece, and people will be more willing to divulge these barriers or their prior experiences once you've kind of made that rapport and validated their experience. So
I feel like she knows that.
She knows all these things.
She knows all these things. Hey, listen. What's your big issue in primary care?
What do you mean?
Well, what's your biggest problem?
What's the biggest barrier for you in treating people you need to treat?
Yeah, let's turn the tables. Now, the focus is on you.
Straightforward. I guess I'm concerned with the idea of like, okay, you see a BMI of 35, you see a waist circumference of 41, and you say, lose weight.
Yep.
Without first like knowing, has your client or your patient experienced trauma because of their
Sure.
the weight that they carry. I think it's really important to ask people.
Sure. What's your experience been before?
Yeah.
Sure.
Yeah, although everyone in this room should know that the ultimate endpoint is for them to lose weight. But, you know, as soon as you see the measurements when they walk in the room, you don't just yell at them. Lose weight! And they're like, yeah, dude, I know.
Like if you were to get them weightlifting for 6 months first before they're willing to talk to you about it, like, there's no harm in that delay.
No, actually, and so I did this.
Those entries for decades.
I did this thing, what was it, the evidence-based behavioral practice lecture. Yeah, in St. Vincent's College, and a big part of that was about using weightlifting as an adjunctive therapy towards dietary modification for obesity. And the idea was I can get a bigger buy-in for dietary manipulation if I can get somebody training and get them keyed up on that. Because then
Caring about their lifting outcomes.
exactly,
Right.
exactly. So 100%. Yeah, getting somebody to care, period, about their health is, you know, sometimes difficult, and I think if you can get them into training, that is a good way to do it. Yeah. But how many patients do you think, if you had to guess on a percentage basis, are on that you're managing for obesity? How many patients, percentage wise of your total panel are you managing for obesity? 10%. Okay. Well,
That's low.
hey, do you want a job? Cool. We have we've got some availability. So
So I have to ask you a obligatory question about chicks, I guess.
Oh, chick stuff.
Yeah, so I mean, there's like the obvious like thing for you with the room, right? And I guess there's kind of the two questions. One being, I'm curious about your thoughts with this athletic training sensitivity spectrum, which I think is like sort of revolutionary and interesting.
I got one thing right my whole life.
Like, what do you foresee? I find it interesting to think about where women in sports go. Like, women in sports is so kind of historically recent that it seems like we haven't really explored like possibilities there.
More interesting than dude sports.
Right, so it's interesting.
That's objectively true.
So like imagining that, and then the other piece of it being like how to make this less intimidating or whatever for women. And to me, there's two parts of that. There's like on the one hand, there's this sort of like traditional masculinity that feels inaccessible or toxic.
Like Britney Spears.
And then there's the other side of it that is, being like claimed by women and it's awesome, but it's like pink and glittery and like hypersexualized often.
Oh yeah, Fitspo.
right?
Break that back, sell the protein powder.
Yeah.
Yeah.
So like,
I work hard so my daughter doesn't have to sell protein powder.
right. Like, how do we not?
All right.
Sum it up.
So the question is, where do women's sports go in the future? Where do we see them going in the future? And number two, making this whole scene more accessible to women, I suppose.
All right. So where do women's sports go in the future? I think that women's sports continue to explode with more, basically every time that there's a sport in general, that there's going to be a women's division. And that the gap originally, here's how the natural history of any women's and men's sport goes. It's going to be a large gap initially between performance, and then it's going to narrow, and then it's going to maintain. So originally they thought in the 80s that the women were going to surpass the men because they found steroids. But turns out the guys found steroids too, and then the gap stayed the same. Yeah, they were like, we predict by 2020 that the women's, 100 meter dash, is going to be faster than the men's. No, they just found steroids for a few years, and then guys found more steroids. Yeah, and their voices didn't change, so it's fine. So I think that's how it's going to go. You're going to, every time that a new sport emerges or becomes more popular, initially the guys are going to be the ones to excel, and then women are going to come in and say, hey, we do this too. And then there's going to be a large gap, and then it's going to narrow. I think actually the only world record now held by women is in the long distance ski downhill jump. So women actually holds that just absolute outright, which is kind of dope. So it'll be interesting to know if and when a sport it comes along where the woman actually holds the upper hand. So it'll be something, and it'll be really cool when that happens. Yeah. I think that as it becomes more widely accepted where women participate in sports via the social media and mainstream media, that you're going to get more women involved. I mean, this is what's happened with CrossFit. This is probably one of the best. It's like both the best and the worst of CrossFit at the same time. Like, the best thing is they've highlighted women doing these things, and so more women get involved. On the other hand, they've highlighted them in very interesting ways that I don't necessarily have a problem with, but at the same time does lead to some bigger questions. Anyway, let's leave that alone. I don't want to get hated on the internet for this. So, I'm pumped. I'm really excited to see how women do. How to get more women involved in training is going to involve more women getting involved in training. So, you are a social change agent. You have a wide group of women who you interact with on a regular basis, and they all need to be training. How do you get them to train? I think that there needs to be workshops, and initially it probably starts out as women-only sort of training things, because that cuts this intimidation factor. But I don't support that widely. I think that suggesting that women and men are different and need their own training thing ultimately just results in this, segregated training experience, and it shouldn't be like that. That being said, guys need to do better at this too. Look, we're screwing this up for women, which ultimately screws it up for us, because by limiting half the population from engaging in something we think is really important, that limits our resources to train. So, we need to be more respectful of women. We need to allow for them to engage in training without, asking them if they need a spot and standing too close to them, or, offering them technique advice and, breathing heavily in their ears. Like, we need to...
Through your mouth.
Yeah, through your mouth. Yeah, so... I am hopeful that as our society becomes more educated and more aware of the inequality between males and females, that there are more guys who are in a position to help women get to the same level do that. So I would love nothing more than to have as many female barbell medicine coaches as male. That would be a win for us. The problem is that in this field, women get to a certain level as far as coaching goes, and then they come to a fork in the road, and they say, well, I can either improve my skill set and become an expert in my field and no one will care, or I can do the Fitspo stuff and put discount code in bio. Do that. And I'm waiting for somebody to choose the first option, right? Present company excluded. So we'll see when that happens. And that doesn't mean that I don't think there's anybody that there's nobody out there doing great things. I just think that the majority of the time, that's how this goes. And I would rather see that there's thousands of women out there who are subject matter experts in this field and they're, getting their piece of the pie. I want that. But right now there's a handful and everybody else is telling you that you can get 10% off if you use my name at this checkout. And that's unfortunate. So, yeah. Question about warm-ups, how they change for mile reps, heavy singles, and sets of 8. Austin?
So I guess I can just give an example of how I might warm up for a heavy single.
Yep.
So, yeah, right. So say I'm going to squat a single at 600 or something. I'll squat the empty bar for anywhere from, let's say, 3 to 8 sets of 2 to 5 reps. I know that sounds weird, but I don't do the same thing every single time. So I've done 8 doubles before. I posted that as a video, and I got so many DMs 48 hours later, can you repost that warm-up video? It's just 8 doubles with the empty bar.
Yeah, my first
What's the big deal?
My first Instagram post that got over 1,000 likes was my video where I did an EMOM for 10 minutes of 5 reps of the empty bar on the minute every minute for 10 minutes.
So a few sets with the empty bar. I don't do
people were stoked.
10 minutes. I don't do 10 minutes of warm up, but if I'm doing doubles, I might do one every 10 or 15 or 20 seconds or something like that. Sets of 5, 2 or 3 sets of 5 with the empty bar, and then go 135, 225, 315 for plate jumps, fairly aggressive.
How many reps are you doing on the way up?
So I'll do 135 for 5, 225 for 4, 315 for a double, 405 for a single, 495 for a single, 550 for a single, and 600 for a single, something like that. So less warm up than you might think.
The way that I would tell people to warm up for a single, though, so you have a single at 8, let's say, and then you're doing 5s after that. I would have you do 5s all the way up to what I would call the single before the single. It's like a warm up single. So for Austin, if he wasn't squatting so heavy, he would be doing 5s all the way up through 495.
Yeah, I'm not doing that.
And then 5, well, I know, but then 550 for a single, then 600 for a single. So that's how that would change as far as my actual prescription for somebody who doesn't already know how to warm up and how they need to warm up. If we were looking for absolute prescriptions, it'd be do 5s all the way up, do one pre-single, and then your planned single. That would be the idea. And the pre-single is trying to tell you, am I okay to go up this week? Because the assumption is that you're stronger this week. Always. No matter how you feel. The assumption is that I'm stronger. I'm stronger, I'm better this week until proven otherwise. So the pre-single needs to tell you that. So for instance, Leah this next week is going to try to deadlift 170. That's her best pull in training she's ever done. Okay, so the single prior to that needs to be heavy enough to tell us, is this a smart jump? If it's less than 160 kilos, it cannot possibly tell us that. Okay, cannot possibly tell us that. So somewhere in that 5 to 8% range is what it needs to be, right? So 5% of 600 is 30, 5 to 10%, 5 to 8% rather. We're talking almost 40, 50 pounds,
560,
something like that. It's close. But how I would have that do, if you're doing a single at 8 and then 5 sets of 5, then the idea is you do 5s all the way up to a pre-single to gauge your top single. If you're gonna warm up for 8s, do 8s all the way up. If you're gonna warm up for a mile rep, I probably wouldn't. Because it's the third exercise of the day, you're already warm. You're gonna pick a set or pick a weight that you think is the appropriate intensity, and you're gonna do it till you almost fail, till it's at 8. So basically, let's go back to that 20. You have 20 minutes to train. What do you do? Yeah, I would put 225 on the bar on a squat because I know I don't need much warm up for that. I could literally I'm going to put my shoes on, I'm going to go squat 225, and I'm going to squat it for, 40 reps or so until I get tired and see Jesus. And that's going to be my activation set. So that's the idea. So for a mile rep, I probably wouldn't warm up unless I was really scared to do something, in which case I would do a range of motion with that particular exercise. But I would pick whatever intensity I think is appropriate, and then I would do that first set until I got to RPE 8. So I thought I had 2 reps left in the tank, which is near failure, and that would be my activation set. Does that make sense? Yeah. So whatever the rep prescription is, do that all the way up. Unless it's singles. If it's singles, you need to do a single before the single to tell you should you go up. And it has to be close enough to your planned increase to give you enough information. Austin knows if 550 moves like pretty slow, he can't jump to 600. But if it moves fine, he's like, I have no reason to believe that 600 will not go today. If it was 500, he wouldn't know. It's too far away. You agree?
With most things.
Bro. The question is tips to stay consistent with nutrition and training whilst traveling. All right, so the first trick is how do you find places to train whilst traveling? So the easiest thing to do is to search powerlifting gym, whatever town you're going to. That's step one. If nothing comes up there, you come up goose egg, then you got to search CrossFit gym, whatever town you're going to, and then look for open gym hours. That way you at least find a place to train, because most CrossFit gyms have what you need. So then you start looking around on the Google to say, do they have iron plates? Do they have squat? Do they have actual racks, or is it all rigs? Which is fine. You can make do, but those are all much better than going to a commercial gym. But in general, especially in America, there are powerlifting gyms all over the place. And then you find out their Instagram, you stalk a little bit, you see, what's the best place to go?
That's actually what we did when we were in Hawaii.
Yeah. Gym tourism. It's great.
Yeah.
Food-wise is tougher. So if you're going to go to a place for an extended stay and you really want to be tight on your nutrition, my advice would be to find a meal prep service, and they will just deliver all your food to you. You don't have to worry about it. If you're only going to be places for a few days, I would see if there's a Whole Foods nearby. You could literally do all this stuff at Whole Foods. It'd be totally fine. And if failing that, my general go-to is most meals should be low carb, low fat, double protein, high protein at the beginning and middle of the day, meaning breakfast, lunch, snacks, high protein, low fat, low carb. And then at the end of the day, you have more freedom to do your thing. Because let's say you're traveling, you're going out, so you're going to have a drink or two, you're going to have maybe dessert, whatever. You've left room for that. Ultimately, so the calories equal what you need to get to. That's my general recommendation. But if I was going to go somewhere for 2 weeks, I'm going to get a meal prep service to help me out. Yeah. You have anything to add?
I have something to add.
Oh, yeah.
Having traveled with you.
Yes.
One of the things I noticed on my first trip with Feigenbaum is that he is essentially maniacally focused on making sure that he trains. Like his main tip and trick is probably the fact that he will not miss training. Like if we're in lots of places, and he's like, okay, where are we gonna go work out? And it's just like what he does, and that is something aside from whatever genetic gifts those two have. The fact is that is a big priority for them wherever they go. Like it's what they do, and so I think that is also that's not. There's no secret so much as it is, and I do not share that. Okay?
It sounds like I could look at a barbell.
But they actually that is something that they would, I think, and I don't mean to speak for them, would probably be direct if they want to do it.
Well, we're not here by accident. Right. How many training sessions have you missed in the past decade? 3.
It was 1 week. I went to Vegas for the first time.
Oh yeah, you were real sick after that.
Yeah.
I remember this.
Yeah.
But yeah, mine was my honeymoon. Just 7 days.
So you missed 4 training sessions
just during that week.
Yeah, I missed 3.
And then I did a meet. And then I came home from my honeymoon. 2 weeks later, did a meet and still performed fine.
He's still fine.
Because where was the guy who asked? Oh, I guess he had to go.
Here.
In a short period of time, you don't detrain that much.
Oh, so, that guy.
Yeah. So yeah, just have not missed training. So finding a way to train is super important. I am not as rigid about nutrition. That's probably another difference here. So I would not personally.
That's why I'm more handsome.
Sure. Yeah.
Although you're married, so
that helps. So I don't do the meal prep thing, but I do similar approach to selecting what I put in my mouth.
Okay. Okay.
Next question.
All right. So the question is, yo, we're working in the equestrian field. How do we recommend strength and conditioning? Well, so if you said like, so how many women, how many girls do you deal with at a time? Yeah. Up to 20. So if you said, hey, before you come to me, I want you to do this strength training program, what sort of buy-in do you think you'd have there? I mean, have you tried?
No.
Yeah, so the first thing I would do is just say, look, you're about to come here in 12 weeks. What I'd like you to do for 3 months before you come here to get yourself prepared to deal with this 1,200-pound animal and the other rigors of the equestrian life, okay, is the strength training program. And it's squat, bench, deadlift, press. They're going to do some chin-ups or whatever, even if it's just twice a week. And the first thing you do is just assess, well, how many people are doing it? If you recommend it and 75% of the folks who come in through your program say that they did it, that's a win. You don't have to do anything. You already won. Now, if you recommend it and 0% do it, then you have to do a post-test before they leave you and say, well, why didn't you do it? And then that's going to tell you your barriers.
Identify the barrier.
Yeah.
Like you were saying earlier.
Yeah, that's what I'm getting at, is that all you got to do is try first and see if it works. And if it doesn't work, then you have to figure out why. But I would just try first, because I bet you're in a position of power. They all have to pay a bunch of money, right? I assume you're not cheap, Reed. They're dealing with horses, which seems fairly affluent. Reed. So I think you're in a position of power where you can say, hey, look, before you come here, you need to do this strength training program. It's going to be very helpful to you in your riding career and to your success within my program. I would recommend that you do it. Here's what you need to know. And all you're saying is, I want you to squat, bench, deadlift, press. Here's the program. You're going to do 2 lifts per day. It's twice per week. One day is squat and press, right? The other day is deadlift and bench press. You're going to try to add weight every week. Do this many reps, this many sets. And then when they come in, you say, how many of you did this? And you find out. You find out what your initial buy-in is from literally doing nothing other than saying, you should strength train. Here's how you do it. And I think if it's over 50%, you've won. And then you just got to figure out, why didn't the other percentage of folks do it? And then that can kind of tailor how you're recommending the things. But if you're asking me how I would recommend for young women who have never trained before to train before they come to you, if you're assuming a fairly low buy-in overall, I would say they're going to train twice per week. One day is squat and press. Why? Because it shares the same rack height. They don't have to do anything. The other day is deadlift and bench press. And that's it. That's the only resistance training that you're going to actually make them do. If you could get them to do more stuff, that's great. But we're talking about going from no training to some training, right? Who knows? Maybe they'll like it after the 3 months and they'll say, well, what else can I do, Reed? And you're like, I'm glad you asked. Horse season is over. Now it's gain season, right? Like, so. Is there a horse season?
Ask him. I don't know.
He said that there was a season.
It's always horse season.
It's always. So, but that's actually what I would do.
Yeah.
That's the thing I would do. And literally, you couldn't go wrong with making up any type of program that you wanted to, unless it included too many things to where it decreased the compliance, which would only be able to be evaluated retrospectively after you administered it. Okay? So I would keep it 2 exercises, 2 days per week, and just see what your initial buy-in is. If they like you, or if they think that you're legit and it is a fairly selective process to get into your program, I think you're going to have a high level of buy-in, which would be great. Right?
And you can use it later on for, say, like promotional type stuff of like, this is how people who succeed in this program prepare for this sort of thing. This is what this requires.
Right.
If you want to succeed at this, this is how you do it. And if people are incentivized or motivated to go do your thing, People who are highly motivated are going to do all kinds of crazy shit, like train 4 times a week for a decade and never miss a session.
Yeah. Or if you're
going to do that kind of thing.
Or if you do curling for Russia, you take anabolic steroids. Who knows?
Yeah. If they're motivated,
Yeah.
they'll give it a shot.
So that's what I would do, and get some data first, and then if you need any help with any of that stuff, you just email us. All right. Tips and tricks for gaining weight. Excuse me.
I'll just bow out of this conversation.
Well, I mean, you gained a bunch of weight.
Yeah, I started training. I was about 158 pounds when I started training.
This dude was tiny.
So I've gained 44 pounds, I guess, here today. Yeah.
Yeah. I gained.
It was slow, but yeah.
Well, I'm getting 50 to this point, and now I'm just like, I can't.
How tall are you?
6'1".
6'1". And
Yeah.
what do you weigh?
220.
I mean, it's not like you need to gain a bunch of weight.
Yeah. I mean, you're getting there.
Yeah.
Use a blender.
Well, so I mean, the obvious suggestions are to use high calorie, more nutrient dense foods, right? And then that are less palatable, or not less palatable. Sorry, less satiating. So have higher sugar content, higher fat content, higher salt content, because they're not going to fill you up. That's the idea. If you're talking about doing chicken breasts and rice, whatever, because all the bodybuilders say that they do that 8 times a day, they're lying. They're lying. And if they're not lying, that represents a psychological abnormality that you don't have. Because if you had that, you would have already been, IFBB Pro. Okay, so I think using, you can either use less satiating foods, more calorie dense foods, right? Or find ways to increase your calorie intake that don't necessarily fill you up. So peanut butter is the cure-all here. Seriously. Or doing liquid foods.
Right.
So whey protein, oatmeal, ice cream, peanut butter, blend, slug it down. Try to avoid the toilet for the next 90 minutes.
Well, that's the thing is, right, so your problem that you're experiencing is that you're getting full too quick, too soon to consume enough calories to gain weight. What are the things that go into satiation that we talked about yesterday? Protein, fiber, water. So less water, less fiber, less protein in the food makes it less filling, means you eat more of it, means you gain weight, right? Yeah. And then also remember the food matrix stuff that I talked about in terms of the physiologic effects that it has on your body as a result of the way that it's delivered, chewing, liquid, all these other kind of things, right? And so taking something with lower fiber, lower water, lower protein, and blending it into a liquid form that requires no chewing and you can swallow it very quickly means that, hey, it's not going to fill you up particularly, that much.
I'll give you some wine.
Yes.
Yeah. I mean, so I probably wouldn't, if I was making a protein shake that was designed to gain weight, it'd be 1 scoop of protein or maybe a 2/3 of a scoop of protein. It would be 2 cups of oats, and then it would be 2 or 3 servings of ice cream plus a serving of peanut butter. But it's not going to be 2 scoops of protein, right? You don't need that because you're getting protein from those other sources as well, plus a bunch of calories. Luckily, it's empty.
Yeah, you've probably already gotten enough protein in from the rest of your intake for the entire rest of the day, and this is just extra stuff.
Yep. You could also make an argument for increased meal frequency, even though you know that there's a refractory period for muscle protein synthesis. That's not necessarily your concern. Your primary concern is getting enough calories in through the day, right? Your secondary concern is, well, how to most optimally spread that. But if you're not meeting the first criteria, you don't get to pass go and collect $200 and move to the second thing. You got to get the first one first.
Yeah.
Okay.
Yeah, I do that very frequently. Violate this dietary refractory period thing, and I have dinner at 7 p.m. or something like that, and then I'm gonna go to bed a few hours later, and I fit 2 more feedings in that period of time.
Yeah, it's probably
so
fun.
that I don't lose weight by the morning, because that's gonna happen.
Yeah, I probably wouldn't recommend pouring olive oil on pizza, for instance, though. Okay. Yeah, or just like mainlining palmitic acid.
Sure.
Yeah. The question is, pregnant women, what to do? So right now, the American College of Obstetrics and Gynecology is the resource to go to for basically any question that you would ever have on pregnant women and what to do about it, as far as what's the next move? What are your precautions, et cetera, et cetera. On exercise, they have been fairly liberal in that they've modified their stance over the years. And now currently it says, hey, whatever you were doing before, you should do it. If you want to start exercising, go ahead and do it. The problem is they say, it probably shouldn't be too intense. And then they don't give any specific recommendations other than it probably shouldn't be too hard. I'm paraphrasing.
Progress from bed rest.
Yeah, but that's where they started, right? So they started from the bottom, now they're here, and it's great. The problem, the issue is because they're non-specific in their recommendations, that leaves this large gray zone, like gray area. Like, well, can you recommend that women regularly engage in resistance training even though they're pregnant? And you could say that, but you'd be wrong, because not every woman is safe to engage in resistance training whilst pregnant. And if you said, well, no, they can't, you'd also be wrong, because you'd be missing a huge swath of the pregnant population who is safe to engage in resistance training that is new to them at high intensities during pregnancy. So what should you do? I wouldn't do anything. I would say you should have this conversation with your doctor, who would hopefully be able to have an educated discussion about the risks and benefits of resistance training or training in general while being pregnant, even if it's new to the person. Here's the main thing you need to take away. During pregnancy, this isn't the time where you're expecting people to hit PRs or where strength is the most important thing, because it's not. You're already making compromises in your training resources, right? Why? Because you have another growing thing inside of you that is stealing your gains. Okay?
It's a tumor.
So somebody was like, should I take creatine while I'm pregnant? And I'm like, well, the risk of taking creatine while being pregnant has actually been studied, and it's fairly low. However, why are you taking it in the first place? If it's to improve performance, the question is, well, you're pregnant, okay? Like, your belt no longer fits. You have to modify your technique maybe on your squat and your deadlift, and we're just trying to train because you like it and because there are health benefits, not because you're trying to go to a meet and set a new PR on your 1RM, although that may in fact happen. Mike Grillo, his wife,
that'd be cool.
Yeah, what'd she pull? 365 for a triple or something, right? Like a couple days before delivery. Yeah. The thing is, she like sumo deadlifted the baby out, like it just like. Right. So anyway, I think the takeaway is we don't know what the risks actually are, other than we don't think that they're that high. Here's why we don't think they're that high. There are not numerous piles of case reports suggesting that women engaging in high intensity training of any sort, with CrossFit being as popular as it is, we expect this to be fairly high.
Yeah.
Resistance training becoming more popular, we would expect it to be very high.
Case series by now.
There would have been a case series of women just dropping dead or miscarrying or having problems secondary to training whilst pregnant. That just hasn't developed. That being said, the risk is probably non-zero, and it needs to be discussed with their physician. My recommendation, if I was in charge of the American College of Obstetrics and Gynecology, would be if I were in charge,
all right,
which I'm not, but if I were, I would recommend to initiate strength training unless there was a contraindication to doing so. So if there's no contraindication, if there's no contraindication to doing so, I think you should train in a way that comports with progressive overload and allows you to get stronger demonstrably, allows you to engage in a recreational pursuit of barbell sports performance. Do you have anything you want to add to that?
I think it's the same answer our rehearsed answer for this question.
Oh yeah, sorry, I blacked out. What happened? There was a glitch in the matrix.